everyone. Welcome back. My name is Hae-young Yoon, and I'm the Managing Director of the International Cooperation and Capacity Building Department at KDI School of Public Policy and Management, and we're located in Sejong, Korea. I'm also a member of the Global Development Learning Network, which is the GDLN's global board and the global secretariat. So on behalf of the KDI School and the affiliates of the GDLN, we want to thank everyone for their support and enthusiasm for our first GDLN Global Knowledge Sharing on the Impact and Responses to the Coronavirus in the Asia Pacific region, which was held on March 16th. There was an overwhelming response to our first GDLN COVID-19 session, so we thought it would be helpful to share our collective knowledge and resources with other GDLN regional associations and any other stakeholders or individuals who can help facilitate the dissemination of factual and accurate information on how to contain and combat this coronavirus. We are also hoping to enhance our respective understandings of the implications this pandemic will have on our economies. Allow me to take this short minute to express our heartfelt gratitude to our speakers from the last session and for today's session. These are all experts in high demand lately, so your time here is all the more precious and we truly appreciate it. Before we get started, I would like to ask and remind everyone to mute their mics if you have not done so already. This is critical to having our WebEx run smoothly. And with that, I'd like to start by handing over our virtual mic to my colleague Gershan, the CEO of the Sri Lanka CLC, who will introduce our first speakers in Hong Kong. Thank you. Over to you, Gershan.
Thank you, Hae-young. I'm Gershan Ablananda from DRC, Sri Lanka. And we are so thankful for this timely webinar to share the experiences in managing the containment of COVID-19 outbreak from Asia Pacific region to the African countries. Our first two speakers are two scientists from the University of Hong Kong, Professor Leo Poon and Professor Malik Paris. And the University of Hong Kong, while responding to the outbreak within Hong Kong, also runs the WHO reference lab for COVID-19. And through that, they provide the diagnostic testing capacity to countries, to other countries. And we in Sri Lanka are very close to these scientists and to the School of Public Health, as the first testing lab was set up in Sri Lanka way back in February 2020. So without much delay, let me hand this mic over to Professor Leo Poon from the University of Hong Kong. Over to you, Professor.
Thank you very much. So can you hear me well? Can you hear me? I want to get an answer. Make sure that. All right,
yes,
good.
We can hear you clearly.
Right. Okay, that's great. So basically, now we are come from Hong Kong and next to China, and then at the end of December last year, there was a rumor about the outbreak of pneumonia, atypical pneumonia in Wuhan, and then everything started. Now, this slide basically tell you the case definition of this COVID-19 in China. You can see that they actually have. I mean, this is the guideline from the China CDC. They have different case definition at different phase of time. So from version 1 to version 7. So you can see that they changed the case definition regularly because once we have known more information about COVID-19, you can see that now some of the criteria, like the epidemiological history, at the beginning, they just restrict this case definition linked to Wuhan or wet market in Wuhan, right? Like the version 1. They pretty much restricted to Wuhan. But subsequently, then they spread out. And sometimes they will include those suspected cases outside Wuhan, or even now they have a travel history outside China. So now, I mean, just want to get your attention that when you define your case, you have to draw a very definite case definition, and then you have to review this case definition regularly, because now at the beginning you may only want to target those who have a travel history to China. But nowadays, basically the disease has been found in many countries. So which type of patient or suspected people you would like to screen? So you really have to think about your country situation. I cannot speak on behalf of you, but then you really have to think through all this process. who need to be screened, who need to be tested, and then you really have to think about it. Now, currently, WHO recommend these RT-PCR assay as the screening test for identifying COVID-19 patient early, right? And there are other type of tests which are available even commercially, but I will talk about it later on. But then what I would like to emphasize is RT-PCR test is the test who can identify patient early. If you want to have a good control or minimize the spreading of the disease in the community, then this will be the test that we will recommend. Of course, there will be quite a lot of logistic issue, like do we have enough tests in doing all this screening? That's something that we need to talk about it later on. Now, so basically, what I would like to say is now these case definitions change all the time. At the beginning, only rely on epidemiological history, but nowadays we will actually add those criteria like the clinical findings and also the diagnostic test result in defining the case, right? So can I change? Right now, now this is exactly what I would say. There will be more cases in future because this case may get into the community and transmit to your people in your own country. So there will be more and more local cases, right? And then you need to think through how you define the case, all right? Right now, to confirm the case is basically have developed clinical symptoms, and then or they may be identified by doctors or they actually visit the hospitals, and then they get tested, and then they have a positive result from the RT-PCR test, right? And now, but do think through that maybe sometimes some of these patients may not actually manage to go to the hospital or manage to go to the clinics and for a test. So how you able to define this? You need to think through it carefully. All right. Now, so right now, I'm in the next couple of slides, I'm going to talk about the rapid diagnostic test which is available for clinical labs. So basically, you are detecting the virus itself or detecting the antibodies, basically immune response induced by the infection. Right. For detecting the virus, there are two tests. One's for detecting the viral RNA. The other is detecting the viral protein itself, right? And so basically, the RT-PCR test for the RNA, or viral antigen test for the viral proteins, right? These could be, I mean, if both assays are sensitive enough, they could be useful for early diagnosis. And then for detecting the antibody, what we know is people start to develop immunoglobulin or IgG, IgM against COVID-19 pretty much start beyond day 5 or even day, maybe in the second week of disease onset. So this assay, the serological assay, may not be too useful for early diagnosis. All right, it will be this serological test may be useful for seroepidemiological study. Say, for example, you want to understand how many percentage of your people in your country have been infected, or maybe the level of herd immunity in the community. This type of antibody test will be useful to give you some answer. But then, if you really want to use this test, serological test, for early diagnosis, this is basically not useful, and you are just basically make the situation worse. Right? And then what we know is the viral antigen test, the sensitivity right now, there's no evidence to show that it's as good as the RT-PCR assay. So, so right now, my WHO recommendation is, if you can, try to use RT-PCR test to make a diagnosis. And then we have not much information about the performance of these viral antigen tests. And there are some countries actually have a problem in using these viral antigen tests to make diagnosis. And then they, at the end, found quite a few of false negative cases. So just watch out and then be careful in using these viral antigen tests. Right. This is the kinetics or the history of the viral infection of COVID-19. At the beginning, you basically susceptible. Once you have exposure, then the virus start to replicate, and then more and more. And then when you start to have clinical symptoms, you basically actually find quite a lot of virus inside the body, which I will show you in the. And then probably in the second week of disease onset, then they may end up in a hospital. Right, and then have the clinical treatment at the hospital. Then at the end, they either recover or die from the infection, right? And then the viral amount of viruses actually is quite low at the beginning, and then it's peak at the disease onset time, right? And when they start to develop fever, cough, and then what we know is the viral titer is actually quite high at the beginning. And then it starts to subside, and pretty much the second week, after day 10, the viral RNA or viral copy number start to decline quite rapidly and below sometimes detectable level. But we know that some patients actually shed viral RNA up to 3 weeks. So, but at a low level, right? So the best time for viral RNA, detecting viral RNA basically will be in this peak window, right? Before disease onset, before the onset or after the onset. I will show you in the next slide. So this will be the best time window using RT-PCR test to detect the patient, right? We know we have evidence to show that those patients who had a higher viral load, right, even before the disease onset, day -1 or day -2, and then they start to decline at day 10. Now, you may say, and why don't we use antigen tests? They also detect the virus, but then the RNA tests, RT-PCR tests actually have quite a good amplifications, so that you can amplify the signal much better than the antigen test. So that means the RT-PCR test is a lot more sensitive than antigen test. And we have evidence to show that, we don't have evidence to show that this test, antigen test, is sensitive enough for early diagnosis at the moment. Right? And then maybe after the day 5 or even second week of disease onset, then the immune system kick in. They start to generate antibodies, IgG and IgM. So that will be the good time to use this serological test to test for the presence of the anti-COVID-19 antibodies. But again, it would be not useful for early diagnosis of COVID-19. Right. Okay. So before I talk about the viral load, I just want to let you know that right at the beginning, in mid-January, we sent the protocol, our protocol, out to our RT-PCR assay protocol to WHO, one targeting the 1B region, and then the other targeting the engine region. So this RT-PCR-based assay was sent to WHO. Now this is available online in the WHO website, and then we provide some positive control for this assay to different countries. And in fact, we have shared these reagents, positive control, primary and probes, to some of the public health laboratory, which highlighted in orange. We have about 50 labs have received these reagents. And countries like Egypt, Sri Lanka, they use our test to identify their first patients. And then we also try to provide technical support. Basically, if they have inquiry, we will actually help to answer some of the questions that you may have encountered in the lab and try to solve the technical problem. Right. Now, in Hong Kong, this is the epi curve of Hong Kong. So basically, you can see the number of increase is quite low in compared to other countries. Because in Hong Kong, we use containment as a strategy. We try to contain the disease. So we have to do a lot of active tracing, a lot of screening to identify patients. If you have a positive case, we will try to do active tracing and then try to contact those who have a close contact with the patients, so that we can able to quarantine them and then and prevent them to spread the disease in the community, right? And in compared to other countries like in Europe and UK, Italy, and you can see that they are spreading quite quickly in compared to Hong Kong and Singapore. Right. Okay. Now this is the strategies for containment and mitigations. Right. For containment, this is what Hong Kong do. We basically will only allow sporadic cases. Okay. We don't want them to spread in the community. Right. So whenever we find a positive cases, we will isolate them, and then for those who have a close contact, we'll try to quarantine them. So this try to prevent local transmissions, right? And then in that case, we basically have to do a lot of laboratory testing to screen a lot of patients, and also a lot of people who have a contact with these patients, so that we can able to identify these patient or individual early, right? Now, but then the problem of this strategy is it is quite resources demanding. So basically a lot of manpower, a lot of reagents, a lot of tests has to be used for containing the disease, right? For the strategy of medications which have been used by European countries, they allow some limited spreading of the disease in the community, right? So basically, they just hope that they can control the spreading of the disease in a reasonable manner or under their capacity, right? And then basically they try to isolate the case if possible, but then they try to use social distancing to reduce the person-to-person contact, which we have been also doing in here. But then the regulations are a lot more relaxed, right? And then the other problem of this mitigation is because of this social distancing, and basically the activity in the countries will be slowed down. So that will be difficult again, very difficult to sustain this type of strategies, and then also have an impact on social impact and an economical impact. Right. So the reason why they want to do mitigations is they try to suppress this peak into a pattern like this. So without any control, you expect that there's a huge spreading of the disease in the community. The number of cases go up quite quickly, right? And then a lot of people will end up in hospital, and some of them may even die, right? So by using these mitigation strategies to try to slow down the spreading in the community, so that the upsurge of these cases will be slowed down, right? And then hoping that they will will not reach the capacity that healthcare service can provide. Okay, so just below this capacity or limit of the capacity of the healthcare, so that we can provide the best service to this patient, like ICU unit, then maybe a respirator and all this. We can able to, if these mitigation strategies, we can subscribe this to here, so that we can provide the best service and maintain the system running in an efficient manner. This is the epi curve in Hong Kong. So these are highlighted in different color. You can see that at the beginning, in January up to early March, right, we don't have too many cases. Right? Many of these are actually local import cases, right, or those who had a contact with these cases. But look at here, right? After March, there's an influx of people from outside Hong Kong, right? In Europe or in America, when the disease is spread in these countries, they all come back to Hong Kong. So you can see that there are a lot of people coming in, and a lot of these people actually are infected with COVID-19 in this country, right, before they come into Hong Kong. And then you can see that the amount of cases of secondary transmissions start to go up because of this index case from imported cases. So again, for your country, you need to think about who will be need to screen, right? So who should be put as a top priority for testing, and then who will be the second priority, and then you have to come up with a plan to rationalize the screening strategy in your own country. Should we screen all the people? Should we screen only those imported cases? Or should we screen those in the hospitalized cases? So you really have to think about this process, right? So far in Hong Kong, we are doing like this. So we have about, the population is quite small, 7 million, but then we are densely populated, right? Hong Kong is very small. So we have a very close contact most of the time in Hong Kong. We live, family can live in a very small living area, and then share a lot of items with each other. So we have a lot of close contact. But then, so that means in Hong Kong, there's a high risk of spreading of the disease between people. So what in Hong Kong we did is we roughly screen, I think it's more than 2,000 now, sample per day of these of our citizens. All right, those who are being screened first, they are sick in the hospital, right? And then those who have a close contact with COVID-19 patients, right? And now we have additional category, like we have referral from outpatient clinics, and also we have referral from general practitioner who have seen some patient who have fever. This suspected case, they will be asked to send sample to a centralized lab for testing, right? And then on top of that, those people who coming from outside to Hong Kong, I mean, those people are from like in Europe, America, they will be asked to provide samples. We will screen those people, and then if we test them to be positive, then we will let them know and then quarantine them, or even send them to a hospital. Right. So this is the screening strategies in Hong Kong, but then we also encourage a lot of non-pharmaceutical interventions like social distancing, school closure, work from home, and cancel mass gathering, right? And then we also ask them to voluntarily stay at home if possible. So improve hand hygiene and wear masks if in crowded areas. So what I'm saying is that apart from doing diagnostic tests, we have a lot of non-pharmaceutical intervention to prevent the spreading of the disease in the community. Right. So this is the form coming from our Hong Kong Health Authority. So basically, these are the people who includes the testing criteria, like those have a fever, respiratory illness, or they have an epidemiological link, like travel within 14 days outside Hong Kong, or they have a contact of any confirmed COVID-19 cases. So these are included as a testing criteria. So I mean, like if they get into the airport, then you have to send this form to them and then ask them to provide sample. Or maybe some of the patients get to a private doctor, and then the private doctor see there's a need. Like for example, they may have a fever, the patient may have a fever or respiratory illness. They will recommend this patient to send the sample to the centralized public health lab for testing, right? Right now, Hong Kong, we accept sputum, nasopharyngeal swab for testing. These are swab a recommended sample from WHO, right? But then we also have additional sample, which is deep flow saliva. We also accept this type of sample for testing because it is much easier for the patient to provide. We don't need a technical healthcare worker to collect this specimen like the sputum and the nasopharyngeal swab. This one basically just like this. We ask the patients or the individuals to actually produce a deep flow saliva first thing in the morning, right? So that's basically the split in the container, and then we'll send them back to the collection site, right? So this is the public information, so you can go to the Center of Health Protection of Hong Kong. They will and this is basically I take it from them. So we have a very clear instruction to the general public how to collect the sample, how to package it, and how to send it back to the diagnostic lab for testing. Right. I think I did not include the slide about the viral load. I should talk about this. So what we found is the amount of virus or RNA in patient peak at the right beginning. So when the patient start to develop symptoms like fever, respiratory illness, they shed quite a lot of virus. Actually, it peaks at that time. It lasts for about a week, and then the amount of viruses start to decline, starting from day 9, and then to a low level after that. And then the other thing that I would like to highlight is we also know that some patients actually had a high viral load even before the onset, even before even before their fever. So there are some asymptomatic people, COVID-19 patients, could be shedding a lot of virus before they have developed symptoms. So you have to keep this in mind, and then you have to also think about how you can able to capture this information in your community. Right. Okay. So this is the end of my presentation. I think it's the best thing that we can do is actually we have a Q&A section, so we can actually able to ask some of the technical questions that you may have, and then we can share our experience with you guys. Over.
Thank you very much. Professor Malik Perez, did you want to add to that before we take questions for you?
Maybe just very briefly. I think just some basic facts about this whole problem. As you know, it is a pandemic. It's going to go everywhere. But clearly, countries that have very high global interconnectedness, major travel hubs like London, Hong Kong, Singapore are going to get affected earlier, right? But wherever you are, ultimately, this is going to reach you. I mean, if you can think about the 2009 pandemic, the swine flu pandemic, as it was called, again, I mean, that reached everywhere in the world. And to some extent, this COVID-19 is behaving somewhat similar to that influenza pandemic. So some countries will get hit early and fast, and other countries may be a bit slower. So that's one point. The second thing is that it is probably not possible, and of course I'm look forward to hearing from the people on the call. I don't think every country can copy exactly the same model from wherever. You really have to think through what you're trying to do, what you can do, and set up a very carefully thought out plan. Now, I don't have a solution for this, and I think each country really has to give some very careful thought to this. I mean, you can't just take, copy New York or copy London or even copy Hong Kong, because each one is a different place, different possibilities, and how you set about it is different. Third, I think, truth which has to be kept in mind is that this is not a short-term problem. It is a long-term meaning 9 months, 1 year problem. So, I mean, you can't think that, okay, you lock down for 2 weeks and it's going away. I'm afraid that is not the case. So when we think about strategies for responding, we really need to think through, you may do lockdown for a short time, but you have to think through 9 months type of horizon in front, and how you, maybe at different stages, you have different measures. So I think these are I think really very difficult, especially for the developing or lower and middle income countries. And I think it really has to be thought through. I mean, clearly, diagnostic capacity has to be set up, because without that, you won't know what is happening. Mind you that, COVID-19 is a severe pneumonia. In every country, you have severe pneumonias all the time. Without diagnostic testing, you won't know what is COVID-19 and what is the usual pneumonia that you see. So it is important to have diagnostic capacity. So I think, so I think these are the points that I want to make. Over. So we are happy to take any questions. Over.
Thank you very much. There is a question from the YouTube audience that I'd like to address. Someone is asking, will a sputum test be better for screening in early stages and also for carriers without symptoms?
Right. So I think the sputum test is probably not as sensitive as taking a nose swab or a sputum. Sorry, your question was sputum. Sorry. Okay. Sorry. So if the patient is bringing out sputum, and the patient actually has lower respiratory symptoms, then a sputum is the best specimen. So particularly if the patient is having pneumonia, sputum is the best specimen. If the patient is only having fever and maybe just some upper respiratory symptoms, then an upper respiratory swab, a nose swab and a throat swab combined probably is the best specimen. Over.
Thank you. There's one more question from Australia. Mass masking is not recommended widely elsewhere in the world. Do you think this is a mistake?
Right. So this is a difficult question, but I think if you look at the evidence of the effect of the effectiveness of wearing masks on, say, for example, influenza in the community, right? So it is very clear that wearing masks in a hospital setting protects healthcare workers. That is definite. It is also clear that if you have respiratory disease, wearing a mask reduces the chance of you spreading infection to other people. That is clear also. And in fact, we have some studies in Hong Kong also showing that it reduces the potential risk of spreading. Now, the question is whether widespread use of masks out in the community, in the general population, whether that has any significant effect. So this has been studied with influenza in a number of studies. And in fact, the WHO commissioned our epidemiology colleague, Ben Cowling, to do an analysis of all the available data. And he has published a paper for the WHO, which is available in Emerging Infectious Diseases, on the effectiveness of masks. And the conclusion is, and this is of course for influenza, right? I mean, there's no study done for COVID-19. And the conclusion is that it is not very clear cut. I mean, there may be a very slight beneficial effect in reducing transmission, at the most maybe 10%, but not much more than that. So I think you have to think again at individual country level. First and foremost, you have to make sure you have masks for your healthcare workers. I mean, that is absolutely necessary. Then after that, if you do have that secured and you have masks available, maybe and if you're having a very active outbreak, when people are traveling out in I should say first and foremost, priority healthcare workers. Second priority, people who have respiratory disease, right? Because it reduces the risk of transmission. So the third thing is what we are talking about. I mean, just normal people who are healthy, is it advisable to recommend mask wearing? And this is what I'm saying, that as long as you safeguard point number 1 and point number 2, and you still have capacity, then you may consider using masks in the general population in situations where the general population is exposed in crowded environments, in very densely packed environments. Now, the reality is that this is, mask supply is limited in many places. So you really have to think carefully again, how you message this, because if you recommend, people to wear masks, you will find that your mask supply, very rapidly disappears. So Singapore, at the beginning, they urged people to wear masks, everybody, and they found their whole stockpile just disappeared in 2 days. So then they have stepped back and they now basically say what I said. In Hong Kong, it's a bit more aggressive. So a lot of people do wear masks, although there is no formal recommendation that general community wear masks, that they do so. So this again is something that has to be thought about carefully. Different countries are going to have different recommendations, but again, each country has to think through carefully. And I think, the point number 1, healthcare workers, is essential. You need to have that sorted out, and then after that, you can think about anything else. Over.
Great. Thank you very much, Professor Poon and Professor Malik Perez. I understand that the two of you have to leave our session early, which is why we brought questions for them in advance. So with that, I'd like to say thank you for your participation today. I know your time was very limited, so we really appreciated you participating today. And with that, I'd like to say thank you and goodbye, and move over to our next speaker, who will be introduced by the chairman of our GDLN board, Professor Glenn Withers, over in Australia. Over to you, Glenn.
Thank you, Hayun, for introduction as well. I'm also chair of GDLN Learning International, which is in the online education area, so important to the situations we're finding ourselves in, because in a way we're walking on 2 legs now. Health crisis, but as a consequence of pandemic, an economic crisis. To have our next presenter, who is Dr. Jay Menon, who is an economist, to talk on that other set of issues, the inevitably issues of inequality and what happens within the economy. Become a lead economist there, and I particularly recall him working on that Cambodia Vision 2030 project as something I was very much aware of, and I know in Australia, including at my university, the ANU. So it's a real privilege to introduce Jay to talk about that second round of crisis type. We've got economic and social issues. So if Jay could guide us a little through that from his base in Singapore, where he's now at the Institute of Southeast Asian Studies, that will be splendid. So over to you. Thanks, Jay.
Thank you very much, Glenn. Before I start, I just want to make sure that everyone can see and hear me clearly. If you could just confirm that you can.
Yes, we can.
Okay, great. Great. Okay, so let me start by thanking the network, the GDLN, for having me talk to you about the transmission mechanisms relating to the economic impacts of this pandemic, as well as a little bit about how it might be impacting the poor, especially both the pandemic and the measures taken to try and curtail it, how it's affecting the poor in developing countries in particular, but in all countries generally. So please let me know if I do break up. I noticed that Glenn's introduction was breaking up, so if you can alert me if you suddenly start losing me, I can then quickly cover the areas that I've lost. But let me get going and start by saying that most of my comments, again, will be based on two blogs that I've written recently on this topic, one on the transmission mechanisms and one on the impacts on the poor especially. And I think the organizers will have them on the website at some point, but in the age of Google, I guess if you just type in my name and COVID, you'll find them very quickly. Right. Okay. So even though I'll speak about the economic impacts, I must start by again reiterating, as the first speakers did, that this outbreak is essentially a human tragedy, first and foremost, a global health crisis with huge human toll on lives and on sickness, and we must never lose sight of that. And especially as economists, when we start focusing in on the economic impacts, we can sometimes forget what the real impact is, which is the loss of life. But having made that qualification, let me talk a bit about some of the likely economic impacts. And here I want to talk more about the transmission mechanisms because there are already many studies that have tried to estimate the impact in terms of the drop in GDP, etc. Lots of them out there, they're increasing almost by the day. I don't have time to review those, except to say that the range varies greatly. There used to be a few studies that said that the impact would be relatively minor. No one's saying that anymore. Now, almost all of them recognize that the impact will be big, massive. It's just a question of how big. There's also a growing recognition that this will be worse than the global financial crisis that we had in 2008. And everyone expects rolling recessions now around the world. The IMF has come out and warned against a world recession this year, but they were quick to say they still felt that recovery will be quick coming in 2021. But it's not just the R word, recession, that's been used and bandied about, but even the dreaded D word, depression is now being used with depressing regularity. So things are not looking good. That's the overall picture. And of course, there's still a lot of uncertainty about how bad it will be, but there seems to be general agreement that it will be bad. The confusion just relates to how bad, right? Now, to try and understand how all of this works, let me speak a little bit about the transmission mechanisms. And I think the first effect that we've already witnessed is the impact on tourism and business travel and all the industries that are linked to them, like airlines, hotels, etc. These have been hit hard and hit quickly, and they appear to be worsening as we go forward, since there appears to be no end in sight for this pandemic. There's also supply disruptions emanating initially out of China, but now reverberating throughout the value chain, throughout the Asian region and beyond. And this is disrupting production. China's role is key in the supply chains around the world, but it's not just about China any longer. And there are supply chains that operate in all parts of the world, even in Africa. Although Africa is not so integrated into the global value chain, there are regional and even national supply chains. And so there's no part of the world that's immune from the phenomenon of interconnectedness through these supply chains. These supply chains, of course, emerged because they produce great benefits, through efficiency gains, but they're also highly fragile. And all we need is one chink in the long chain to break, and the whole supply chain can collapse. And unfortunately, this is what we've already started to witness. The pandemic is also affecting labor supply because of various quarantine measures and lockdowns and so on. But the impact through labor supply will depend on the duration of the measures put in place, and also can vary by sector. So manufacturing has already been very hard hit because physical presence is required. But service industries are less sort of impacted because of a lot of the technological aids that we can call upon now. And the best example is this whole GDLN seminar that we're having. It's not stopping the spread of knowledge and activities such as this, because technology has come to our aid. So in some sectors, it's having less of an impact on productivity, but in manufacturing and other industries that require physical presence, the longer the lockdown or the quarantine lasts, the harder hit will be those industries and sectors. So all of this is translating into sharp declines in domestic demand, and these drops in demand will feed on each other. So there'll be a compounding effect. Lower demand means lower production means lower incomes means lower demands. And on it goes, on and on it goes. So these compounding effects can magnify the initial drop in demand and extend what are short-run effects into the long run. Right. But the highest cost may still come from the so-called intangibles. These are the ones that you cannot easily see or measure, but are very real. And these include the effects of general negative sentiment about growth, and also overall uncertainty about the impacts, about the virus itself, and how it will all pan out. Now, this is already affecting financial markets, which are moving up and down on a daily basis, mostly down. And eventually it'll feed into the real economy and will result in lower investment, consumption, and in lower growth as we go forward. And the final outcome is, as we expect, rolling recessions, or hopefully not even a depression. What we will see is unemployment and poverty rising sharply, and all of this despite the mounting stimulus measures that are being contemplated all around the world. Okay, so I'm afraid it's gloom and doom, but we hope that there will be some breakthrough in addressing the virus going forward, and that's what will actually be the solution to the human tragedy as well as to the mounting economic despair. Okay, now very quickly, let me turn to some of the impacts I think we can expect, especially in developing countries and amongst the poor, which I think might be of greater interest to our audience. Right. Now, the COVID-19 virus has been described as an equal opportunity infector. This is by Dr. Brilliant, who helped eradicate smallpox. This basically is true, but then the poor are generally more susceptible to being infected, and the poor are also suffering disproportionately from the measures that are being put in place to curtail its spread. Right? This is nothing new. All man-made tragedies or natural tragedies, man-made or not, tend to have unequally high negative impact on the poor. This is true for earthquakes all the way to climate change. COVID-19 is not an exception. The conditions under which the poor live basically make them more susceptible to all diseases, including COVID-19. Now, poor countries also have very limited data available that they can use because of limited testing. So they are groping in the dark in large measure, and decisions are being forced to be made not based on data, but on the lack of it, guided mostly by fear, right? And also a presumption that overacting or overreacting is always justifiable. Now, I'm not too sure about that, and I think the circumstances in poor countries force us to reconsider that presumption, whether overreacting is always justifiable. A cost-benefit approach should be employed to try and decide how far you go, how quickly you go to try and curtail the impacts of the curtailment measures and the disease. I don't often agree with President Trump on almost anything, but I think when he says that the cure might be worse than the ailment, there might be something in that. No, not for his country, of course. It's a whole different picture in the US. But if you were to apply that to developing countries, I think it carries some weight because the conditions are very different. Now, even without evidence of rapid community transmission, lockdowns are already being pursued in an attempt to try and nip it in the bud. This is the idea that if you act quickly and act hard, you can stop the spread and stop the exponential growth. Now, this approach gains further support if your healthcare system is weak and you have limited resources for healthcare, and then prevention becomes the best option. Prevention is better than cure, especially if the cure doesn't exist, and also when treatment is limited. And I think this is what is guiding the very draconian measures being employed, let's say, in countries like Philippines and Thailand and Malaysia right now, even though data doesn't point to any level of rampant community transmission. But these shutdowns or lockdowns are having huge costs. Let me just quickly quote from an anonymous Indian doctor who has the following to say about the measures and their impacts on the poor. He says, social distancing is a privilege. It means you live in a house large enough to practice it. Hand washing is a privilege too. It means you have access to running water. Hand sanitizers are a privilege. It means you have money to buy them. Lockdowns are a privilege. It means you can afford to live in a home. Most of the ways to ward off the coronavirus are not accessible to the poor. They are only designed for those with the means. And I think this needs to be borne in mind as we go about thinking about what should and can be done in poor countries in trying to address the spread of this virus. We also have to bear in mind that lockdowns are time-bound. They are not sustainable. They cannot go on forever, right? And in countries with large amounts of the poor that have to scavenge for a living or live from hand to mouth on a day-to-day basis, shutting down the economy may stop the spread, but it will start killing people because they will be deprived of their livelihoods. And this is something that that affluent countries don't need to contend with and have the luxury of hitting it hard and using draconian measures, but may not be available to very poor countries. So to finish off, let me say, I think if there's no clear evidence or indirect evidence of rapid community transmission, a gradual approach that may be the harm minimizing option for many developing countries. Start with a combination of international controls and domestic social distancing measures that stops mass gatherings and other communal public activities, but does not threaten livelihoods. And then review these measures as data becomes available and be ready to change them as often as you need. This is not about putting the economy over lives. It's about saving the economy so that you can preserve lives, especially the lives of the poor. There is a long way to go in the war against COVID-19, but policy needs to be responsive, not just to trends overseas, but to how response and mitigation measures are working domestically. There is no gold standard for the response here because not all countries can afford to implement those sorts of measures if the consequences outweigh the benefits. What we should try and do is gather as much data as possible and use data to drive our policy, not fear. Overreacting without adequate safety nets can actually be as negligent as complacency, and if it leads to vulnerable groups suffering irreversible harm. So I think I'll stop there and thank you for your attention and look forward to your questions. Thank you.
Thank you very much, Dr. Menon. We're going to save the questions for the rest of the speakers to the end of our Q&A session. So right now, what I'd like to do is I'd like to go over to Tanzania, to our affiliate there, Mr. Brown Hasunga. Will introduce us to the speakers so we can hear more about how Africa has been preparing its response to COVID-19. So over to you, Tanzania.
Okay, thank you very much. Also, maybe we'd like to thank everyone for participating in this thread, COVID-19. Here we have two doctors who are going to share about COVID-19. These are National Task Force doctors. So first we'll start with maybe Lady. I think she's Lady. You're not ready? Okay, so Dr.
He will start and then I will go.
Okay, Dr. Hokororo, please, this is your time maybe to share anything about COVID-19. You're welcome.
So thank you very much. Tanzania, like any country, like any other countries in the world, and in this case in Africa, is also fighting against the pandemic, Ebola COVID-19 pandemic. And the preparedness, actually, as a country, we started early when the first case was announced in China. From there, as a country, we started preparation on how to respond or fight against the epidemic. We first prepared the healthcare workers, because these are the frontliners whom, when the case arrives or when we get the case, are the ones who are going to be facing them. So we built capacity, and actually we are continuing to build the capacity of healthcare workers who are attending the patients. But the various teams which are needed to fight the epidemic or the pandemic, the contamination teams, the lab scientists who are needed to take samples, and other teams who are involved in this fight. But also, we prepared the supplies and equipment which are needed during the responding against the pandemic, like personal protective equipment, chemicals, like antiseptics and disinfectants, which are needed during the response. But we also identified the facilities countrywide, whereby in case of any patient will be present or available, recognized in any council of the country, should be placed. So in every council in Tanzania, we have around 182 councils. And in each council, we have identified the area whereby when we get a case, can be kept in that place. But also, we used the available media to actually give the community, the entire Tanzanians, to be aware of the pandemic. So all the medias from televisions, radio, magazines, all participated to convey message to the public that we have to take measures. Everyone should be involved to protect themselves, and at the end of the day, to protect the entire community. We thank also our president, who came forward and convey a message to the public that everyone should be involved in this fight. We have to take measures at the individual level and at the community level. Everyone should take measures of doing hand hygiene, try to distance themselves, and even here we have set at least 1 meter apart in the distancing, and to reduce gatherings. And actually, the government decided to close all the schools, from primary schools to universities. And as soon as we got this first case around 3 weeks ago, we activated the national team for response. And all the regions where the cases are available, also they have the regional teams to respond to the epidemic. And actually, we are continuing to build the capacity of healthcare workers who are involved in taking care of those patients. And we have teams who are following the contacts. I think Dr. Janet will be able to elaborate that more. But also, we continue to educate the community that they should take part, protect themselves, doing hand hygiene. Don't go out if you don't have anything of importance to go out. And in our country, we have just done the partial lockup. I mean, partial closure or partial lockdown, yes, partial lockdown of the services. So we have some challenges because of that, but we're still trying to reduce the gatherings, especially those which are not needed. And in the midst of the transportation, for example, we are still having challenges, but at least we have advised those who are giving that service to reduce the number of people in their buses or any other means of transportation. And even our parliament, currently we are having the meeting going on, and they are showing it by example. Instead of going all the members of the parliament to attend the meetings, though they reduce the number to the half of them. Offices which are able to work from home, also they're doing so, working through e-office, using the technology which we have. And we have the toll number, whereby those who feel to have some respiratory symptoms, they should be able to call and get some instructions on what to do. And if they are advised to go to the hospital, or the team can follow him or her and assess and find out if it deserves to be a suspect case or not. So all those are some of the issues or interventions which the country has done to make sure that the pandemic is reduced. And as a national task force, we are having meetings every day to follow up what is going on daily, follow up our patients which are having, follow up if we have new cases, and those who are getting better. Thank you. I think Dr. Janet can continue from there.
Okay, thank you. I think he has tried to share what we are trying to respond to COVID-19, but also we have another presenter who is going to share with us, Dr. Janet Mgamba. Please, you're welcome.
Okay, Dr. Janet Mgamba, I lead one of the surveillance committee within the National Task Force. And just to add on what Dr. Hokororo has said, most of our response measures are guided by the disease transmission pattern. And to date, we have almost like 20 cases, but then only up to 6 or 7 of the patients are imported cases. And we have now seen a different pattern. Initially, we had secondary cases, that is local transmission, but now we have tried also to map some of the contacts, and we have already identified some of the important key transmission pattern, which is community transmission. And Dr. Hokororo has already clearly articulated what we are doing, and this is based on our scenario now that there is community transmission, and we have revised our strategy, and that is why the National Task Force, which is led by the Prime Minister, has advocated for closure of some of the gathering, and we are thinking that one of the areas which we might be able also to revisit is the issue of screening. And we are very glad to hear the presentation from Hong Kong about particular areas where we might need also to expand our response in terms of really now we have the community transmission, understanding how we could do the screening and which particular type of tests could be used in screening. So this for us is one of the key important area which we really feel that we would want for some of you to shed us more light. In terms of contact tracing, this is an area which is a bit of a big challenge for us. So we have categorized some of the contacts. There are high-risk contacts, and then there are also low-risk contacts. And one of the strategies of which we are using, the high-risk contacts, we are placing them in an institution for close follow-up, but then the low-risk contacts, we are following them at home. And this is an area where we are putting a lot of investment in terms of recruiting more people to assist in contact tracing. So currently the epicenter is in Dar es Salaam, which is one of the regions in Tanzania, as well as Zanzibar. So in a nutshell, maybe really like underscoring that our response mechanisms are really based on the transmission pattern, and now we have the community transmission, and we are revisiting some of the strategies. Yeah, thank you.
Okay, thank you. I think you have seen it from Tanzania, one of the African countries. So back to you, Chairman, please.
Thank you very much. Like I said, we will continue on with our speakers and then go back for our Q&A session. So what I'd like to do is go over to Sri Lanka again, who will introduce our speaker from the WHO. Over to you, Gershan.
Thank you, Em. And we have Dr. Sopmal Dhanapala from WHO. He's not new to us. He has been there for the first seminar also. He is a professional officer from the emergency response team from the WHO Sri Lanka office. And without much delay, I'll pass this mic on to Dr. Dhanapala. Over to you, Dr. Sapu.
Hi, can you hear me and see me?
You can see and hear. Thanks.
I hope you can see my presentation on the big screen. Can you see the presentation on the screen?
Yes.
Yes.
Thanks.
Okay, so thank you very much, colleagues, for giving us the opportunity again. As WHO and the World Health Organization is actually trying our level best at 3 levels to guide countries and ensure that the key the latest evidences are put forward to countries so that you all can actually implement them in your countries with the support of your national the WHO officers, and of course you will have regional support and also global support in like we have in Sri Lanka. So I'm the National Professional Officer of Sri Lanka in the World Health Organization. So bear with me for about 15 minutes to go through some of the latest evidences that I felt that you all should also know, and I'm sure I can answer any questions and after this presentation. So just to reiterate some of the key messages that WHO has been saying through our DG every day is that this pandemic can be controlled. But to control the pandemic, you need to have a comprehensive approach, and also containment is one of the major objectives of your response in your countries. If you can do that, then you buy time to have your health systems geared to manage each and every case. So the WHO understanding is that, and we actually, our DG is calling all country heads to encourage countries to take proactive measures so that we can change the course of this pandemic. So if you just look at the numbers, which is alarming, I'm sure all of you have these numbers. So we have over 800,000 reported as of yesterday morning. And alarmingly, you will notice that there is 72,736 confirmed cases in one day. China's 4 months of this outbreak, they have only a little over 80,000. So you can just imagine the magnitude of this situation in all the countries. And we as a world have to come together to support each other at these difficult times. If you look at US and Italy, their numbers have exceeded 100,000. And if you look at the deaths, Italy and Spain alone, their deaths have increased more than 8,000. There are 5 EU countries which are also having a magnitude of a very high scale, where they have over 50,000 cases. And there are another around 5 additional EU countries which are having over 10,000. Globally, it is very unfortunate. And as a physician, we feel really not so happy with this situation to see unnecessary deaths being portrayed, because these deaths could have been prevented. So roughly we have over 40,000 deaths reported, and yesterday itself, for one 24-hour period, we have lost 4,192 persons. So if you look at the global pandemic, what is alarming here is, you look at the first 100 cases, it took 67 days for the first 100 cases to be reported. Second 100,000 cases, it took only 11 days. And the third 100,000, 4 days. And now it just within 2 days, you have the number. So I'm sure in the next 24 to 48 hours, we will have the 100,000 cases in one day, which means that all our countries have to work together to support each other and share our resources. We thank this organization for sharing with Africa, because I know the African region needs a lot of support from all of us to be prepared to ensure that they provide the best care for their people. So if you look at the number of cases report, you will see that initially it was China, and now it has gone to Europe, and the Americas are now having a larger case. So we in Southeast Asia are lucky that we have very strong systems in public health, where we have a very strong surveillance systems, and that has assisted us to ensure that we are able to control it to a manageable level. It's not that none of our countries are affected, all our countries are affected, but we are trying our best to curtail it as much as possible. Even large neighboring countries like India are trying their level best with a population of over 1 billion to curtail it as much as possible. So if you look at the number of cases reported over each day, you can see it is going up every day. So which means we are still in the upward trend of this pandemic. The good news is that if you look at the case fatality ratio, as this was displayed by WHO even at the initial stage, the case fatality ratio is very low at 2 compared to MERS and SARS. So preventive measures make a big difference if we want to ensure that we control this pandemic globally, and of course save lives as much as we can. Another good news is that if you look at the model of WHO, you will see that we have only 5% of them requiring critical care in your intensive care facilities. Now to do that, we need to have a boost of your intensive care, but no amount of beds will assist us if we don't have your preventive measures in place to test, to detect, and to make sure that we have social distancing. If we don't emphasize on these areas, no matter how strong your health system is, it is going to burst at the top. And I'm sure the countries around, if you just look around and speak to the doctors in these countries, you will see how sad they are that they cannot provide the best medical care that has been taught to them to prevent death. So this slide was shown earlier. So what we try to do with social distancing is try to bend the curve. And if you see our regional countries, most of it has been able to do it. Even in Sri Lanka, this is what the government has been able to do. Bending the curve to such a way that we can manage the patient load that is coming, even if we have an unlikely event of a secondary wave. So it is important that we emphasize this with our governments and have a whole government approach and whole societal approach if we want to win this war against COVID. So if you look at the spread and the numbers of increase, it is not doubling or tripling, but within within 10 days, it will have large outbreaks in your country if you don't do surveillance and take early preventive measures. So I'm sure most of the countries are now have cases, and most of them are in sporadic and cluster cases in the African region. So we need to ensure that these measures are done according to WHO guidelines so that we prevent it from going from a clustering or a sporadic cases into community transmission. And that is where we can make a biggest difference to contain this. And Sri Lanka has done it. I'm sure the other countries can request information from your WHO Sri Lanka office or the WHO CRO office, or even you can ask the Minister of Health in their areas and how they were able to do it. So if we act early, you can control this disease. And this slide, I'm sure all of you all have seen. So and it reinforces the importance of trying to prevent it from going to community transmission. So these WHO 9 areas, we all need to emphasize that all 9 areas have to be given equal prominence if we want to control this epidemic. It makes a big difference if you can emphasize on all these 9 areas with the respective heads of states and the leaders in the health sector, the health minister and the director generals of health in your countries, because this is something that we really emphasizes, and I'm sure you will understand the effort that Sri Lanka has put into trying to contain it as much as possible. Would like to emphasize the 3 shields of protection, because this is something that we need to all get together and do. The first is to protect our own health workers. As you have seen, in Sri Lanka also we have issues where some of the health workers were exposed because the patients didn't actually divulge their information. So we have had 4 teams now in home quarantine for 14 days. But we have to ensure that the health workers are given the necessary personal protective items so that they can provide their humane care to the best of the ability that they have been trained. The second is the population at risk, and that's why we are appealing as WHO, please take early measures to prevent this from spreading from the clusters to community transmission. Third is to protect the vulnerable countries, but unfortunately, most of the countries are now reporting numbers of cases. So, but we need to re-emphasize our support. So the DG and WHO calls upon all the countries to have a whole of government approach and whole of society approach. As mentioned, we need to scale up the emergency response mechanisms. We need to have very close communication with the people. The reason is because the people's compliance will make a big difference in ensuring that safe distancing, hand washing, respiratory etiquette, etc. are emphasized and practiced. Need to isolate the areas through surveillance, test and treat every case and trace every contact. And we need to have our health hospitals ready so that they can manage the patients who come and with compassion. So the area of stigma has to be thought of well early in your response, and you will see the amount of stigma that was created against the Chinese when it started, and I'm sure when you see social media and the media, the amount of stigma which is still attached. So it's important that we take this up seriously with the governments, have media etiquette in reporting, that they should not unnecessarily discriminate these people who come forward with the cases, because if we stigmatize these COVID patients, I'm sure you'd have experienced the same thing with HIV/AIDS. These persons who are exposed to this virus will not come forward, and then that will going to create a huge a wave of COVID in your own countries. So it's important that we address this well in advance so that we take preventive measures and encourage the society to come out if they have been exposed to a COVID patient or have been traveled overseas, to come and report to the closest hospital and get proper medical treatment. As DG said, I'm sure you'd have seen this, that stigma can drive people to hide the illness to avoid discrimination. And that is what we need to stop at all costs. And also they will stop people from seeking health care, and they will spread to the rest of the community. And also the people will not adapt to healthy behaviors. So some myths that have been going around that WHO is trying to reinforce are that this is a droplet transmission. We have a window of opportunity having a safe distance, but that is only in the community. But if there's procedures being done in ICUs or in patients, then you need to have the full personal protective equipment to prevent the health workers from getting infected. But that is only for the health workers who are doing those procedures. The general public are extremely anxious. They are worried about the wearing of the mask, and of course the transmission, and it's that needs to be told to the public by the health professionals and get them to be convinced that they need to not to worry about using surgical mask if you're healthy, but use it only when you're required, like Professor Malik Piris rightly said, and he is one of the best, and I must thank Hong Kong University because they supported us establish the laboratory facility in Sri Lanka within 48 hours of us getting the first case. The area of mask, as I mentioned, there are enough WHO guidance on that. Please go to the WHO guidance and see the information. We need to have a triad system in hospital in preparation for large numbers. We also need to have the recognized space and the supplies. We also need to ensure, like I mentioned, that we protect the health workers. There is also WHO guidance of rational use of personal protective equipment and items. Please you read through that and we encourage you to use them in your countries wisely, so that in the unlikely event that you have a community transmission, you have enough PPE stocks to manage and protect your health workers and the actual needy people. There is also, if you go through the WHO websites, there is also recommendation for care of patients based on the severity. They have said guidance note on if you are mild, moderate, how do you treat patients, and moderate with risk factors, severe critical patients, how those persons should be managed. It is also scenarios are given as to the health system priorities that should be given based on each of these 4 stages of the pandemic, and the public health measures and social distancing remain the same for any of these scenarios because most of the countries globally have been affected. It is also important that we think of the screening mechanism so that our health workers are protected, ensure that we identify the person correctly, and then send them for isolation and proper treatment. So the screening for COVID-19 has to be done systematically and using the case definitions which are given by WHO, and you can adapt it to your country's scenario. So we need to also emphasize the consideration of primary health care. As Professor Malik said, there will be many patients with respiratory illnesses other than COVID. We need to ensure that we differentiate who the COVID patients against the non-COVID patients. In our region, we have influenza A, influenza B also circulating. Likewise, in your countries also, I'm sure with ILI and SARI surveillance, you will know what is circulating in your own countries. We need to have organized consultations and community care, train ourselves, and ensure that we educate our community correctly. So most important is this, the countries where they are leaders and the drivers of this response, we need to protect you, me, and the staff who are actually involved in this entire process. Just a few epidemiological insights just to reinforce that we can control this disease. Diagnosis, 80% of the cases are mild and moderate, so that we don't need ICU facility for all the patients. It's only about 5% who require, and now the latest evidence shows with oxygen therapy, you can reduce the severity. The disease of progression is also given in percentages. Exposure, symptom onset, if it's a mild to moderate, it's 2 weeks. But if it's a severe case, then it might go up to more around 6 weeks. So we would like to re-emphasize and try to ensure that the community supports these areas of washing their hands frequently, health workers and anybody else. If there's no soap and water, then you can use alcohol-based rub. Avoid close contact with anyone, especially when you go marketing or when you lift the curfew to buy your groceries, when you go to the supermarkets, or even if you go to the health care facilities, ensuring that you have this a distance of at least a meter or 3 feet. So ensuring that respiratory etiquette, that is, if you have a cough or cold or something, wear a mask, and if not, ensure if you sneeze or something, you sneeze to the elbow, flexed elbow. If you have been identified as exposed to the COVID-19, we expect everybody to stay home, self-isolate. It is what we mean expect by self-isolate, that you need to be separated from the rest of the family, because we know if you have extended family and your grandparents or your parents are there, if they are exposed, the chance of them having a complication and mortality is much higher. So it's important that we re-emphasize that when you do home quarantine, it is not that they should all get together and have meals together and have social gatherings among the family, but ensuring that these people are kept so that we have physical distancing even in the house. We also need to encourage the people do not touch their mouth, nose and eyes as we've seen, and as there is no specific vaccines and no treatments identified for viruses, so we need to ensure that we practice these preventive measures, primary prevention measures to ensure that we protect the community, and early detection and strengthening the surveillance in your countries, and have appropriate treatment to manage the severe. And if we can do this jointly with the non-health sector support, that is because, as mentioned earlier, there's a lot of issues with the daily wage earners not getting their income. So we need to have a social net to support them, to have their local essentials procured, food, which is the most important thing that everybody would look for, water, and the other basic necessities. We also need to take an example from the other coronaviruses like SARS and MERS, where research showed that it can remain on surfaces for a few days. So it's important that we use this opportunity to clean these surfaces as much as possible with soap and water. If not, use the normal detergents that your country uses. The microbiologists do not recommend any additional protective additional disinfectant. The normal ones are good enough. Important thing is, if you have credit cards and mobile phones, everybody uses mobile phones, those have to be disinfected using alcohol base. So we sometimes talk about hand washing and clean the surfaces like wooden surface, etc., and we forget that the closest thing that you handle is your credit card and your mobile phones. So it's important that we get this message out to the public. I would like to end by saying that we need to support the WHO and the world leaders in trying to control this pandemic. Like I mentioned, there are over 1 billion people who have been asked to stay home, and basically in almost all countries. It's important that we all stand together to think about them, pray for them, and try to do our best in each of our countries to control this pandemic. If all of us work together, we can control this pandemic to a manageable level and try to reduce the deaths as much as we can. And that, as professionals and as doctors, and I'm sure all of you, your main aim is to ensure that we save the lives of people in this world, and we need to make this world a better place. So there are enough references on the WHO website. If you can go to the WHO headquarters website, you will see all these clinical guidance and everything given in detail. It is being updated by WHO staff at headquarters who work 24/7 and with consulting with the regions and the countries. There are also the updates of the daily situation reports. It's important that you all also have this daily situation report. Go to the Ministry of Health Epidemiology website, you will see the Sri Lankan situation report every day published. And it's important that we also need to gather the support in Sri Lanka. We need the military forces to ensure that isolation and quarantine are ensured. The reason is because being developing countries, we need their support with the police to ensure that people actually practice. But on the long term, it's the health staff who will have to take the messages of hygiene forward to the public and try to make a difference in their personal hygiene and social distancing, especially physical distancing. So once again, I'm willing to answer any questions after these entire presentations are over. We thank as World Health Organization for the organizers for inviting World Health Organization to be partner in these efforts. Thank you very much.
Thank you very much, Dr. Sapu. And finally, I'd like to go back to Australia and have our chairman, Professor Glenn Withers, introduce our final speaker today. Over to you, Glenn.
Thanks, Haiyong, and I'll quickly introduce our speaker from Canberra. She's stalled in Canberra at present, but of course has massive experience in countries such as Afghanistan, Darfur, Uganda, Nigeria, Myanmar, South Sudan, Zambia, Congo-Brazzaville, Democratic Republic of the Congo, Papua New Guinea, Indonesia, and was particularly involved in responding to the Ebola outbreaks. This is Kamalini Lokush, who's head of the Humanitarian Health Research Program at ANU. So it's my delight to introduce her to join the conversation and contribute her insights about some of the questions and issues we should be looking at, given that background, that wonderful background she's got to help guide us in this area. So thank you, and over to Kamalini.
Thank you, Glenn. Everyone can hear me?
Yes.
Yeah. Thank you. It's a privilege to be here, and I want to start by saying it is a privilege to hear the speakers that have preceded me. And as a medical epidemiologist who is also a health worker, has trained in Australia, I think Australia has much to learn from our previous speakers, and I congratulate them on what they have achieved in their countries, given constraints that many of our countries that haven't managed to achieve it are not dealing with. So thank you. I spoke to Glenn. I didn't want to do a presentation. I wanted to speak on behalf of some of my colleagues, particularly those who are working and have been working in the countries that were most affected by the West African Ebola outbreak. And what they are seeing is a marked drop in access in people utilizing healthcare. So in those countries, routine healthcare, particularly for maternal health, for child health, has diminished greatly. There's much less people accessing care for life-saving but routine health services. And I wanted to start a discussion and get some insight from the fellow speakers, but also from those who are listening, how we address that. And is it possible to maintain routine health system functioning in a context where there is widespread community transmission? And is that something we are giving ourselves false hope around? We've seen even in very well-resourced settings, it is not possible to maintain routine health system functioning when you have widespread community transmission. So should, as all our previous speakers have said, our focus needs to be limiting community transmission. And then at the same time, what do we do to ensure that communities trust health services? Thank you. That's all I want to say. I would be happy to answer questions, but I'd like this to be a discussion, and particularly to hear from fellow speakers.
Thank you, Kamalini. Why don't we go over to Tanzania, and maybe if your speakers can address what Dr. Kamalini just referred to, if you're seeing this happening in your country. Over to Tanzania.
Okay, thank you. I think they're ready to respond.
Were you asking about disruption of some of the essential health services? because I didn't really
community trust, community accessing the fear around accessing.
Community accepting the fear.
Well, so I think one of the biggest challenge in addressing the COVID-19 in Tanzania is actually the fear, and people really not understanding very well the mode of transmission, because we have currently, I think globally, people have access to so many information from the social media, and this is an area where we are really concentrating, that is risk management and community engagement, and we are engaging, we have started engaging the religious leaders, really giving the right information, and as well as now involving the CSOs and the NGOs. So we really acknowledge that but this is an area where we are really concentrating in terms of align the anxiety, align the fear, and giving the right information at this particular right time. And as you already noted in our earlier presentation, we are actually now seeing elements of community transmission, and this is now where our main focus is now changing the strategy and really ensuring people understand what needs to be done in terms of social distancing and some of the key IPC measures at community level.
It's over. Thank you.
Thank you. Carmelina, did you want to comment on that? Or I can actually follow up with a question from our viewers to Tanzania as well. One of our viewers is asking what screening techniques are currently being utilized in Tanzania. Can you speak to that? Over to you, Tanzania.
Yeah, but so the Tanzania, first of all, we are using the Sentinel surveillance sites. We already have almost like 10. Okay, so we have almost like 11 influenza Sentinel sites, which we have established them during the H1N1. And these are the sites which are scattered around the country, and we are using them to really like understanding the pattern, because now we have community transmission. This is an area where we will be doing the sampling of some of the key influenza-like illness cases, and we will also be able to really like revise our testing strategy as well as broaden our case definition. So this is an area where we would really want to go into the direction. I think one of the challenges of which we have now, we are using the real-time PCR, and it's important for us to really like expand and broaden our lab diagnostic technique. There have been some discussions of using the gene expert machine, and we would really want to understand whether a country has used gene expert machine in terms of looking on the burden, that is the lab diagnostic area. So we still be using the RT-PCR, but clearly we are also expanding the possibility of using gene expert machine. Over to you.
Thank you very much. We also have a question for WHO. Dr. Sapu, if I can have you back on. If you could speak to any updates on an effective vaccination coming out anytime soon. One of our viewers is curious about that. Over to you.
Thank you very much. Like all countries are requesting, if you want to eradicate this disease, you need to have a vaccine. So there are a lot of countries who are now in the forefront of doing different stages of clinical trials, and we are confident that they will have a vaccine out soon. But how soon is the question that we are asking. So most of the epidemiologists, if you know, there is a process that they need to follow with these clinical trials. So the WHO HQ is closely following up with all these agencies which are developing a vaccine. So we need to strengthen our preventive measures and curtailing measures until we get the vaccine in mass scale to us. So my appeal is, let's start working on today's, trying to have the primary prevention methods, ensuring we do contact tracing properly, and have our hospitals ready to manage, and even if and try to get the numbers to as low as possible, so that when the vaccine comes out, then we will be in a position to eradicate this disease.
Thank you very much. And a question for Jay over in Singapore. Can you advise on any good economic and social policy responses that you've seen thus far in any particular country? Over to you.
Thank you. Thank you for that very good but difficult question. I guess let's look at the experiences. The countries that have had rapid community transmission and have suffered the biggest toll in terms of death have implemented complete lockdowns as well as shutdowns. And they have seemed to have worked very well in Wuhan so far, and Italy showing progress as well. So that's when things are, dramatic, and you have rampant community transmission. That's, I think, quite clear. The difficulty arises when you're not sure of what the conditions are in your country and how much you can do. Now, if you're not sure, but you do have resources and you do have a safety net, then I think you can probably err on the side of caution and implement more than less. And, developed countries like Australia can do that and can get away with it in a sense without causing a lot of unintended harm and other social consequences. Countries that are not that lucky, that don't have the safety nets in place, must be a lot more careful. So if you look at Indonesia, for instance, right now, Indonesia has resisted going all the way or going a significant long way towards draconian measures, unlike Malaysia or Thailand or the Philippines. And they've received a lot of criticism for that, but the argument there is that the potential costs of lockdowns might outweigh any benefit from controlling this spread of this virus. Only time will tell. So I think there's no clear-cut answer, but what I would say to conclude is there are a lot of measures that we can put in place that will not threaten livelihoods or threaten lives in developing countries that we need to consider carefully. Even shutting down schools are not a good thing, but they don't threaten lives. Shutting down all kinds of public gatherings and all kinds of introducing all kinds of social distancing measures without completely shutting down the economy must be considered in poor countries, in developing countries. And in the worst case scenario, the lockdown is the last resort. But we cannot use it as the first measure, as the Philippines and Malaysia and Thailand appear to have done. Without any clear data to support it, they've gone the whole hog. Now, they can't do it for very long. And so the question remains, if it doesn't work, what next? That's all I have to say about that.
Thank you so much. I also believe we have Kenya and Lesotho also connected via WebEx. If you'd like to respond to Dr. Kamalina Luger's question about what is happening in your respective countries with the loss of focus on managing other types of health and medical priorities, please let us know and we will hand over our virtual mic to you.
Perhaps I could follow up on Jayant's comment and ask a question of Sapumal. Sri Lanka has, as far as I know, successfully contained community transmission. what has been the impacts and what is the plan? Sri Lanka is not a, not a very wealthy country, but they have managed, so they have a strong public health system. I think that example perhaps is more relevant than maybe Philippines and countries without such strong public health systems.
Do you want me to discuss that?
I would like you to. Hayong, do is there time?
So I think like you mentioned, thank you very much for highlighting the Sri Lanka's government's proactive action. The reason why we felt that we should take all precautions early, and if you see, there is a position paper also done by the College of Community Medicine of Sri Lanka, who have given their views on this, very strong views. As a college and as the medical group, they felt that it was better to start early than to lock down after we have deaths and cases. So the government actually took WHO's advice and the directions and went through the 9 strategic areas. They prepared a strategic prepared response plan. And when that was presented to His Excellency and showing the scenarios of in Korea, Japan, China, and the region at that time, before we had these the large numbers in Europe and in US, the president took a proactive decision that he will try to curb this as early as possible, because for us in our region, we need to ensure that we try to give the best to the public. I know we are going through a lot of hardship with these mandatory lockdowns, but the government has taken that step, and the WHO is continuing to discuss with the government to ensure that the services and the essential needs are met. The government is trying different options. The main issue that the government has is that as soon as curfew lifts, people go back to their queuing and not maintaining their safe distances, etc. There is also economic impact, and the Chamber of Commerce has been discussing with the government, and little by little we are easing the systems thanks to the UN team and the diplomats and the private sector. So we have the tea industries working, we have the fishing folks going out to sea, we have the agriculture sector working, and the industries are slowly taking up their numbers and gradually trying to support. We are trying to also help the economy by we have industries who can actually produce N95 masks and surgical masks and the PPE items, which is in short supply globally. So the thought is that try to get the industries also going little by little, and also we need to also think about the Sinhala and Hindu New Year, which is coming up in April. So I think this year the government will have to take a decision that we will not be having it to the scale that we normally do, and try to ensure that anyway, as you are aware, April is a slow month for Sri Lanka, and we use this opportunity to somehow make sure that this transmission is curtailed at family cluster level. The large number of cases that we saw 2 days ago was because of these large the families who were in a very poor housing type of neighborhood, and the transmission couldn't have been prevented because of this the small space in their housing unit. So those are the things that the other countries also need to think about, and the decision by the government or the Ministry of Health is that if the contacts are housed in a very small, tiny area where we feel that physical distancing is not possible, then they are transported to a quarantine camp and they are given a better facility, so that we don't have these family clusters also coming. Especially we are very worried about these family clusters where the elders also are there. In Sri Lanka, we have the extended family system. So if the elders get it, so if you look at the 3 deaths, all 3 could have been avoided if we had that proper physical distancing and ensuring that they are protected from the index case of transmitted to family. So I think that's the approach we are doing. Whether we will be successful and thing is something that only time will tell us. So different countries are doing different things, but with the good intentions. And I think our region is doing reasonably well, I should say, with the least developed economies. And I'm sure India is also doing their very best with the largest country, as I mentioned earlier, try to curtail, because for them, if they are talking about billions. In my country, we have only 22 million, but in India, it's 1.23 billion. So I think these are lessons learned. I hope our African colleagues actually can go through our experiences, discuss with the governments, with your WHO country office NLC, and what is the best time. And it is better to take early preventive measures than be sorry later.
Thank you, Dr. Sapu. I think given the limited amount of time, we need to close at this point. Unfortunately, we couldn't get to all of the questions that I'm seeing pop up on our YouTube streaming, and we hope to get to them by emailing your respective questions to our speakers today. But with that, I'd like to thank everyone for joining us today. We want you to stay connected with the GDLN by either liking us on our Facebook page, which is GDLN Global, or visiting our website, gdlnglobal.org. Please note that we will also have a third session for GDLN COVID-19 for the Latin America and Caribbean region on April 16th for LAC time, or Latin America time, and which will be early morning on April 17th. So please stay tuned and check our gdlnglobal.org website or our Facebook page for updates and additional information. And with that, I'd like to leave you with all the advice that we've been hearing throughout the last couple of hours and the last couple of weeks with regards to how this pandemic has changed the life as we know it. Shelter in place if necessary. Practice social distancing, and please remember to always wash your hands. Stay safe, and hopefully we will see all of you or most of you back with us on April 16th for our Latin American segment of our GDLN COVID-19 series. Thank you very much, everyone. Thank you.
Thank you.